we actually, at this last meeting, there was actually appreciation, which I was like, what? I literally, I'd be walking through the expo hall and it's probably like 3 or 4 times, but people would stop me and say basically some version of keep up the good work or appreciate what you're doing, that kind of thing, which is new because it used to be sort of, whatever, like I wouldn't say mocky, but sort of just not appreciative.
Yeah, but you're not a pariah in that field, the way that you are in, say, dental sleep medicine.
It depends on who you ask. I mean, there are definitely people in the field of ENT who think. I'm trying to think of is there a fine line between pariah and devil? Because people have literally used the word devil in my community.
Why?
Because they don't agree with my treatment philosophy. Mm. And they agree with how they are cherishing and trying to protect the way that things are and have been. Mm-hmm. And I'm coming and saying, like, nah, we got to throw that out.
It's just the fortress mentality there.
Yeah, I mean, it's sort of, I sort of long ago stopped trying to psychoanalyze people and just accepting the fact that if I'm going to do what I'm going to do, that a certain segment of the population is going to like it. A certain segment's going to be neutral, and a certain segment is going to hate me. And the thing I was asking about you about this last time is that the hate part is sort of like extreme. It's like, whoa, and that I'm talking about my community. There's little pockets that are like extremely like agitated, mm-hmm. and I think, in my opinion, those people have never, certainly those are the same people who would be unwilling to sit down and have a conversation with me. Mm-hmm. And I don't know if you actually listen to anything about what I say. There's anything actually that controversial. Mm-hmm. It's just disruptive to the status quo. Mm-hmm. But again, I said I'm not psychoanalyzing. I'm not a trained psychoanalyst, so yeah. I don't know what to make out of it. But
yeah, but I mean, so I wouldn't say devil, but pariah in dental sleep medicine. In talking to a lot of my friends in that field, mm-hmm. many of them would say that what you're doing is a disservice to the patient, mm-hmm. because you don't have a dentist involved in the delivery and the monitoring and the follow-up of patients with when using oral appliance therapy. And as a result of that, they cite these examples. Well, I had one patient that said, or I heard from a guy,
sure,
that this patient wasn't treated optimally, and not all avenues were explored before maybe ceasing oral appliance therapy or managing a side effect.
Mm-hmm. How do you say this? I don't know how that makes me. I guess, is it better for somebody to have access to oral appliance therapy? Even, let's just call it slightly suboptimal compared to the sort of the Cadillac version, or is it better they just don't have access at all? And no, you can't give me a statement of, well, you could just get them in with a dentist. No, we cannot. I guess I keep coming back to that statement is we cannot. We simply cannot. And I don't have, so it, then I would go, all I would say to those individuals, I'd say, be really careful about the rocks that you're throwing in the direction you're throwing them in. As you're throwing that in the direction of somebody who happens to be capable of treating the entirety of that breathing triangle, starting with the nose, going to the throat. And all I would say is, how many of the patients that you're treating are you putting in oral appliance therapy that have never had a proper nose evaluation or are being suboptimally treated there? And I'd say, I'll guarantee you the percentages are going to go way over the top on that. So I'd say, I'm suboptimal, you're suboptimal. I'm doing something in my, sort of sphere of influence. And let's just, I guess at the end of the day, here's what my common refrain is: let's give me 10 patients, give me 100 patients, give me 1,000 patients, and I'll take my model and my process up against your model and your process every day of the week, and I don't care who you are or where you're coming from. Our process works.
What I find so unbecoming about a lot of these conversations is that all of these people, yourself, these dentists that I'm referring to, have the patient's best interest top of mind. I mean, it's the driving force. You disagree with that?
I disagree with that.
Go.
Yeah, I think that they say that, but I simply go back, and maybe it's simply just maybe we have a different definition of having the patient's best interest in mind. My definition of patient's best interest in mind are all of the people out there suffering from these issues, not just the small handful that are actually walking into offices. So the patients that we're treating at Advent, some of them walk into other offices, but the large, when you look at the percentages of diagnosed people who have sleep apnea, we're in that 80%. We're treating the 80% of people who aren't diagnosed to begin with. And so we're doing the hard, tortuous work of basically expanding reach. So no, we're not. I will take an imperfect model and apply it to a maximum number of people, but we're actually doing something versus the perfect model and apply that to a minimal number of people. And that's the difference. And so I guess my definition of patient extends beyond the patient that's sitting in front of me. It extends to everybody out there who's suffering from these issues. Their definition of patient is simply possibly the patient that's sitting in front of them. And I will say I'm definitely very passionate about. I guess I'm impassioned in a way that I don't know. I've not seen anybody else quite be that impassioned. Which I don't know how you say that. Which is probably somewhere where some of the pariah aspect comes.
Sorry to keep coming back to this, but I'm going to.
Sure.
You don't have a dentist involved. There is a side effect. Say a crown comes out. What does your team understand that you're not directly hands-on with that patient in most instances? What is your team? What do they do?
Yeah, I mean, it depends on what is going on.
A crown came out.
A crown came out. I'm actually not part of our oral appliance therapy program. I would assume they would get them in with their dentist and address that issue. Yeah. I mean, every single patient of ours has a dentist that they work with. We do have a dentist that's involved with our program that oversees all of our clinics. So we would, I assume that's that doesn't happen frequently, but I'm confident that we have a protocol for that. I just don't know that.
You do have a dentist involved.
Yeah. Current state. The question is how are they involved?
Please.
Yeah, we have a dentist dentist on staff who oversees our program, who's available to consult with our providers if complications arise, who oversees and signs off the protocols that we have. So I guess therefore, therefore, what do we not have? We don't have, I guess I feel like we're sort of splitting hairs because in my understanding for high volume dental sleep practices, the amount of times that the dentist is actually involved in the treatment is minimal to none. Minimal. True. A high volume dental sleep practice, the dentist shouldn't, if they're really running well, a dentist should only be involved when a dentist is needed. And it could be needed from an insurance standpoint or needed because there's a problem going on. But otherwise, it should be the remainder of the staff should be doing 99% of the work.
Not 99%, but
95, 90, you pick a percentage. But,
but the dentist is involved much more than that. But to your point, or I think to the point that you're making, the dentist isn't doing all of the heavy lifting, seeing this patient at every single appointment, spending all of the face time, but they're spending a significant amount of time. I guess we've got to define what that is, but it's not just, they are spending face time with every single patient.
Yeah, as are my clinicians. Again, you could say, well, what's their training? And I'd say, well, what's your training and what's your breathing triangle training? We can go back and forth on that. And I'd say, I think, how do you get good at oral appliance therapy? I mean, I don't think anybody came out of the womb ready to go on oral appliance therapy, and I don't think they got any training in dental school. So I think all those degrees are great, but I think as far as how somebody gets good at oral appliance therapy is by doing volume in oral appliance therapy, having good training to begin with, learning from the reps that you get, becoming better. And I'd say as an organization, we get better every day by doing, and we have a lot of learning to do. We're not, is our oral appliance therapy program perfect? It is not. Is it on par with anybody else's practice? It is. Can we get better? We will. What I will say, and when you combine that portion of our practice along with the nose and sinus portion of our practice, we're capable of doing something that nobody else is. And that's something. And that's something worth doing. And it's something that I'd say, and again, I guess I've said this before, is I'm ready, willing, and able to work with the dental sleep community. But the definition of work is not sending you patients from one of my clinics. That doesn't work. So what that means is we currently have 20 clinics. We're growing. I absolutely would be interested in understanding, is there a model that would work to be even more collaborative than we are, what we are. As an example, I think for all of those dentists out there, dental sleep medicine practitioners and dentists who have patients who have nose problems, there's nothing better. There is no access to something like Advent until Advent exists in your environment. So I think there is absolutely a natural collaboration that's there or should be there between Advent and dentistry and dental sleep medicine. That doesn't preclude us from offering oral appliance therapy in our four walls. Those things are not mutually exclusive. In fact, they absolutely they currently do coexist.
If a dentist refers a patient to Advent,
yes,
what's the likelihood that patient for nasal treatment? What's the likelihood that Advent's going to make an oral appliance for that patient as well, rather than referring them back to
zero?
Really?
Zero. That will never happen.
How do you ensure that?
Because you're talking to the person who runs this organization. That will never happen. If it does ever happen, I guess that will. If I'm aware that that's happening, that will be rectified, but that is never the intention. That's true for anything, honestly. When I say anything, I think oral appliance therapy is the best example of that. So for dentists in communities where Advent exists, and you're seeing patients who have nose and sinus problems or potentially nose and sinus problems, and you want to put them in oral appliance, but you're concerned that I'm not sure how they're going to do. The best thing to do would be to send them over our way. We'll get their nose evaluated and working. We'll get them back to you and do what you need to do.
So you're going to be speaking at the Transform Dental Sleep Symposium in February.
Yep. Is
the aim just to get up there and tell everyone to hold your breath until Advent opens up in their market?
I don't have my talk down yet. I think as a current state, my aim is simply to explain this paradigm. I think it's just because I know we've talked about it, and I don't know how. It doesn't seem that complicated to me, but I think I think the pathway forward starts with a common understanding. And to me, the breathing triangle is the map for that understanding. Can we all come to an agreement that these issues are interrelated? Can we all come to an agreement that simple, effective options are optimal? And really just trying to kind of start from there. That's my hope and my goal, is just to simply get on the same page. We can have differing opinions on, what do you do for this portion of the breathing triangle? But I think if we can't sort of come into agreement on that, or at least maybe come into agreement / have an open and honest conversation or discussion, then everything else is sort of, I wouldn't say a waste of time, but it's, you're just talking around things. But to answer your question, I'd say, what am I going to tell the person in Idaho that is willing to acknowledge that the breathing triangle is a concept and a construct is something that makes sense to them, that understand that in an optimal ideal world, we'd be able to work together, sort of thing. But you're not here to help me, today. What I'm going to tell that person, I'll mumble and stumble like I did before and say, I guess what I'll say is, if we can accept and agree on this framework, then I'm going to do my best to get to you as quickly as possible. And when I do, we come in peace. We want nothing more than to collaborate with you. There are way more patients out there than are currently being treated. And my goal is to help to make that happen. And I guess maybe the other thing I'd say is until we get there, and even when we're there, in the markets that we're in, we raise awareness for airway issues. We raise awareness for oral appliance therapy as a treatment option. We assist our dental sleep medicine colleagues in raising the tides for treating folks. So I actually, as a specific treatment, to me, oral appliance therapy is a downstream treatment from the start of the airway. As a downstream treatment, I wish there were more people on that playing field, because we as an organization, that's not our focus. I mean, it really just to be clear, that is not our focus. We have sort of done it begrudgingly because our patients need that option. And so, yeah, I would love nothing more than the dental sleep community to dominate the sleep appliance space, period. Mm-hmm. So, and I'm here as an ally, as an advocate, nothing more than that. I'm also, I have my opinions, and
why couldn't you have just stopped?
Because I never can stop. Why everybody asks, why can't you just stop?
Here's the line: you just want to.
No, but I guess I'd say I am passionate about these issues, and I over the kind of the remaining arc of my career, raising awareness is something that I am going to do, mm-hmm. and I think for those people who are willing to kind of stand beside me, whatever, next to me, behind me, whatever you want to call it, I want to help to lead the charge on this, mm-hmm. and that'll be good for everybody. So, yeah. No, I think it'll be a good thing.
Well, I commend all the work you're doing to increase awareness, to help more people, and look forward to seeing you in February, and hopefully everyone comes in peace and leaves a little smarter and a little more ready to take action.
That sounds like a plan. See you in February.